Good evening, everyone. It has been a good, long conference and first time virtual. And I thank AIOS for giving me this opportunity to be present in this conference. And this is the last session. I'll be talking on introduction to chorioretinectomies. So chorioretinectomies were first introduced by Zimozo Norvik when he did a therapeutic chorioretinectomy in 1987. But as a prophylactic mode of preventing the PVR, post-traumatic PVR in patients, it was used by Ferenc Kuhn in 2004. What is chorioretinectomy? Where is chorioretinectomy done? Is in deep impact ocular trauma, where we have incarceration of the vitreous, or we have a penetration of the choroid, and it is supposed to reduce the RPE proliferation, the fibrous ingrowth, and PVR from the wound side. It can, as I mentioned earlier, it can be done as a prophylactic or a therapeutic procedure. So what is the method? It's a triamcinolone assisted vitrectomy is done with or without base shaving. Then a deep 100% diathermy burns are given around the incarceration site. And then the incarcerated retinal tissue is removed with underlying choroid to the level of bare sclera. 1 to 2 rows of prophylactic laser are done around the wound site. And any bleeding which is happening is controlled by diathermy or by increasing the infusion pressure. So this is to understand the concept of chorioretinectomy. I'll just present this case of a 28-year-old male who had a double perforating injury in the right eye with end of. You see here I'm cleaning the lens and the exudates in the anterior chamber. And once the AC is cleaned, this exit wound was, this entry wound was sutured. And after that, vitrectomy was done. All the vitreous hemorrhage and the exudates were removed. And you see that there is an exit wound along the inferotemporal vessel here. At this moment of time, I did not touch it. It was a little bit of necrotic retina. And what you see later on, 2 months post-operatively, although the media view was clear and ophthalmitis was controlled, but there was a thick fibrous growth from the exit wound extending to the fovea. And this usually happens in these type of deep impact trauma patients. And if you just remove the ERM, it will keep on recurring. You will remove it n number of times and it will recur n number of times. And the best corrected vision at this point of time was just counting fingers of 1. So we took the patient again for surgery. We removed the epiretinal membrane and then we trimmed it. You see the membrane was extending into the subretinal space. We trimmed the membrane. We applied 100% deep diathermy burns, sparing the major retinal vessels. And after this, with the diathermy itself, we tried to melt off the choroid as much as possible. Whatever was left was eaten up by the vitrectomy cutter. So post-operative, again, 20 days post-op, the patient's vision had improved to 6/24. His fovea was clear. And 2 months post-operative, again, the vision was 6/18. Though there was some intraretinal hemorrhages due to some BRVO, due to this chorioretinal excision, but it was not affecting the vision. So this is 1 year post-operative. Again, the patient is maintaining a vision of 6/18. This is the second case, 21 years male, perforating in eye. On body, I call this mission impossible because it was a suprachoroidal intraocular foreign body. And you see there was a thick fibrous band extending from the vitreous into the retina and into the subretinal space. And foreign body was nowhere to be seen in the vitreous cavity or even seen embedded on the coats of the retina. Then you see this was, the fibrous incarceration was quite large. We did 100% deep diathermy burns again, covering whole of this wound site. And then Again, we removed the excised the choroid using the vitrectomy cutter. The choroid as well as the retina and the overlying fibrous tissue was excised. There was some bleeding happening, but it was easily controlled by using diathermy and by raising the bottle height. And you see, once we had excised the choroid, there the foreign body was just lying below the choroid. It was then again separated from here and was removed using a handshake technique. Was removed. It was lifted using active suction, was passed on to the foreign body claw forceps, and was removed through this additional sclerotomy that we had to make. After that, the patient underwent silicone oil injection, endo laser 360 degrees, and silicone oil injection. And this is 6 weeks post-op. The patient's vision is 6/12. Macula is healthy. This is another patient, a 32 years male, injury with a knife, and he had a retinal detachment with vitreous hemorrhage with incarceration. And you see, there was vitreous incarceration, a large amount of vitreous incarceration associated with the retinal detachment. In this patient, so we again started doing a diathermy around this incarceration site. So first we did a retinectomy in this patient, sparing the choroid here. We just did a retinectomy to free off the retina from this incarceration site. Because it was a huge incarceration, it was in the periphery of the retina, we decided not to remove whole of the choroid from here. What we did in this patient after doing the retinectomy was along the retinectomy edges, we just created a 1 millimeter zone of a choroidectomy. We just did a small strip of choroidectomy around this incarceration site, about 1 to 2 millimeters all around. And again, after that, the retina was settled, the laser was done, and silicone oil was used as a tamponade. And this is post-operative, 2 months post-operative, the patient's vision was 6/60, and 1 year post-operative, silicone oil had been removed earlier, and the patient is maintaining a vision of 6/36 in this eye. This is a patient recently came to me 2 years post-operative, and he's still maintaining his vision. Some other cases, this was a large intraocular foreign body. It was removed, the chorioretinectomy was done, and you can see there's hardly any post-operative previa. This was a patient of diabetic retinopathy who had an iatrogenic injury with the cautery tip during vitrectomy, and you can see after the first surgery with the silicone oil, there is a fibrous ingrowth from the wound side. And when we did the SOR, we did a chorioretinectomy here, and the patient had a good recovery. Another patient, with the cow's horn injury, he had a total vitreous hemorrhage with anterior carceration and a posterior incarceration. This patient too, we did a chorioretinectomy at the incarceration site posteriorly, and the patient recovered a good vision of 6/18. Though this patient had a one recurrence, but we were able to ultimately recover good vision. Another patient of a double perforation with the post-operative vision of 6/9 and no recurrence. And there are some other non-traumatic applications of chorioretinectomy. This was a 36-year-old female, best corrected vision was 6/36. And there was she was a known case of angiomatosis, exudative RD, and macular edema. She had undergone multiple sittings of laser and cryo for 2 years, and she had undergone multiple injections of intravitreal Ozurdex. And this was a patient, she had a large angioma in the periphery. And in this patient, we did You see, we did endodiathermy around this tumor site, and first of all, I thought it will only be a retinal hemangioma. I'll just take out the angioma, but when we tried to excise the angioma, it was very adherent to the underlying choroid. So we had to do a chorioretinectomy in this patient. See, you can easily see now we started doing removal excision of the angioma. You see, it is adherent to the choroid. So we planned a chorioretinectomy in this patient. So we were able to excise the whole of the tumor along with the retina and the choroid. And we did diathermy at the base of this tumor. And then we put a long-acting gas as a tamponade in this patient. We did a fluid. You just have to take care in these large excisions of choroid. You don't use excessive air pressure. It has to be very soft, or you can do a PFCL, silicone oil exchange. Otherwise, you can have serious complications like venous embolism due to air going into the veins. And this is 6 weeks post-operative with patient's vision had improved to 6.12. So take-home message is chorioretinectomy is a relatively new procedure. It may prevent exit site wound-related PVR and fibrous growth over the retina from the wound site, and it may be considered as a prophylactic or therapeutic option. Thank you.
Thank you so much, sir. It was a wonderful presentation. We'll take the questions at the end of the session, sir. Towards the end, once all speakers have spoken.
Okay.
Yeah. So moving on to our next speaker, I would like to invite Dr. Saurabh. Sir, very warm welcome, sir. Requesting you to please share your screen.
Sure. So I thank Dr. Guha sir and AIOC for this opportunity. And I will be speaking on choroidal detachment drainage. I'll be sharing my screen now. Can you see my slides?
Yes, sir. Would you please put it on the slideshow mode?
Yes, sure. Can you see it on full screen?
Yes, sir. Yes, sir. It is visible. Good to go.
So as we know that choroidal detachment, we often encounter in various settings. It may be, associated with a rheumatogenic retinal detachment or post-trauma. And I'll be speaking mostly on serous choroidal detachment drainage because the suprachoroidal hemorrhage will be dealt on later. So this is a case of a rheumatogenic retinal detachment with serous choroidal detachment, and this is the pre-op picture. And in the left eye, you can see bullous total retinal detachment with choroidal detachment in this patient. And I'm just going to show you this video, how I drained the serous choroidal detachment. So I'm just making sure that, I'm trying to get an entry into the vitreous cavity, but as you can see, I could not see the tip of the instrument. And so I'm just withdrawing my 25 gauge trocar cannula just a little bit, and you saw some choroidal detachment being drained. So I go inside and start the vitrectomy, and you can see the bullous nature of the retinal detachment, also the choroidals, but still the choroidals are increasing. So I just come out and use the same technique again, withdrawing the 25 gauge sclerotomy trocar cannula and draining the choroidals, and then again making sure that my infusion cannula is inside, and then I could finally drain the choroidals and finish my surgery. And you can see I'm doing endo laser, and still a little bit of choroidal detachment was remaining, but I could finish my surgery. And this is the immediate post-op picture in this case, where you can see that endo laser burns and a little bit of residual serous choroidals which finally subsided. And this is a late post-op picture and with a totally attached retina. But this patient did develop a macular hole, as you can see in the OCT here. And finally, this patient underwent silicone oil removal with ILM peeling and a closed macular hole. So This is another technique which actually it's courtesy Dr. Manisha Agarwal from Shroff Charitable Hospital. She does an endo drainage of choroidals as well. So I'll just play her video. So after making this, retinotomy plus entry into the choroid, the flute needle is used to drain both the retinal detachment as well as the choroidal detachment, and then endo laser is done. So this is endo drainage of the choroidals, and then silicone oil was injected, and this patient did well. This is the immediate post-op picture and the late post-op picture at 3 months with a vision of 624 N9. And another technique which has been described by Dr. Sangeet Mittal is using the intracath or the controlled cannular drainage of the choroidal detachment. I'll be showing his video now. So he uses this controlled cannular drainage with the intracath, which is put into the suprachoroidal space. And in his hands, this works very well. And then he attaches it also to the controlled suction. And you can see the choroidals going down as the foot switch is pressed of the automated suction. And what are the advantages in his hands? So this is a case of post-scleral buckling with recurrent artery and choroidal detachments. So you can see that these are the posterior loculated areas of detachment, choroidal detachment, which can be entered using this technique, because anteriorly you have the buckle effect. So you can see the tip of the external intracath in the suprachoroidal space. And with controlled cannular drainage, again you will see the choroidals go down. And drainage is done from multiple sides. And you can finally see the choroidals going back. And this is another case in which the cannula is left behind and even endo laser is done. So this technique works well. So, and to end my presentation, this is the last video I have to show, that in choroidals you also get very bad PVR. So this was a case of bad PVR, recurrent RD. So how I managed with the silicone oil in situ, you can see that a lot of membrane peeling was required. So I did it with silicone oil in situ because it helps to act as a third hand and keeps the retina pressed, gives counter traction for membrane peeling with oil in situ. And then finishing the peripheral vitrectomy, doing air fluid exchange, and then doing laser and silicone oil injection. So this patient did well. So we must understand that choroidal detachment does not only involve drainage of the choroidal detachment, the serous choroidal, but also managing the complications like macular hole, which I showed in the earlier case, and also a recurrent RD with very bad PVR, which was managed with membrane peeling with silicone oil in situ. Thank you.
Thank you so much, sir. I thank you to finish the presentation before time. So for the questions, we would be, as I said, we would be taking the questions at the end of the session. Now I move on to our next speaker, Dr. Ramandeep Singh, sir. A very warm welcome, sir.
Yeah. Yeah.
Requesting you to please share your screen, sir.
I'll play my video now. Thanks to Dr. Guha for this wonderful opportunity
coming straight to my talk, the indication for colorectal biopsies has not really changed for a long time. Infectious, uncontrolled, relentless uveitis involving the retina and the choroid remains an indication apart from the tumors involving the retina and the choroid, where the clinical picture is not classic. What we say is they masquerade actually. Only found that which has happened in the last 1 decade is people are using it more and more for CRBs in case of uveal melanomas because they want to patient of uveal melanoma before they do 73. The transcleral, a lot of changes since then, last 5 decades. He started with ab externo approach, that is transcleral, which is still relevant in present time and still can be used for anterior large tumors. So by making a partial lamellar scleral flap, as we do in filtration surgeries, the inner flap and the tumor segment is taken as a biopsy. And once the diagnosis is made, then this area and the tumor has to be appropriately treated. So it was a difficult procedure for the posterior tumor, so it gave way to the other ab interno techniques. And first came this full thickness biopsy, which became popular first, especially when both retina and the choroid were involved. Later, now there have been they have been done for the eye. The tumor size is small, or where the transvitreal biopsy has failed. But in cases where retina and choroid are both involved in uveitic conditions, still it is being advocated. So what is important is instrumentation, because the large gauge instruments are still relevant here. Area of biopsy, hemostasis, and these are the things which we have to plan while we are trying to take a large colorectal full thickness biopsy in these patients. The area, the side, are very important actually. So this is one of our patients where we treated this patient, was treated with Ozurdex, and infectious uveitis worsened, came out to be toxo-positive, we treated with toxo treatment, but he showed initial improvement, later worsened actually to the extent that he had vasculitis which bled, and we went for surgery and we removed these sheets of blood, and inside we still found the retinitis which has increased more. So we thought that better to take biopsy in this patient because patient is kind of locally immunocompromised because this was Ozurdex was given. This is how the side of 2 by 2 mm is prepared. Normal retina and the abnormal retinal part is taken. You can do pottery also. I prefer laser. So you want a 4th port, large 20G, because you want to insert a 20G vertical scissor to carry out this dissection, which is done inside the plane of the laser. Once you see a whiteness of the sclera, you know you are in the right plane. Then you just have to feel the toughness of sclera and keep cutting with the vertical scissor. Some bleeding will occur, but you have to take care with the bottle height. Retina and the choroid sometimes separate from each other. You have to make sure that the vitreous has been completely removed so that it doesn't happen. Once they are separated, you have to take it out with the appropriate forceps through a large wound, and then it is sent for the handled for the sampling and for the preservation, as done in this patient. So as we are moving towards the minimalistic approach to avoid the complication of bigger gauges, this has happened here also in the retinal choroidal biopsies. Biopsies with the smaller gauge cutters were introduced, and this completely replaced the needle biopsy, where the yield was poor. So it was useful. It was shown that it was useful for the tumors more than 3 millimeter. And vitrectomy, no vitrectomy, these are the two techniques you use. It. Dr. Prithvi, he is a good friend. He says that it works in tumors, 0.8 mm tumors also. The catch here is more is the bigger is the tumor height, more is the yield, more are the chances of picking up the diagnosis. These are few tips he says. No full vitrectomy, high VAC, low cut rate, and you have to cryo the wound sites and treat the patient appropriately in this no PPV transmitted technique. Other technique which we use very commonly in our uveitis patients and in our lymphoma patients, that is we do PPV along with it because we tend to take vitreous biopsy also. So in this patient, like you see, this patient is again the relentless progressive retinitis happening in the both eyes. We went ahead to take the subretinal biopsy and the vitreous biopsy. You will see that we do not use the saline first in the eye. We make sure that we take the undiluted vitreous sample, and it is taken with the help of an assistant and under very low VAC and very low cut rate to avoid the damage to the cells. And this is all underdone in the air. You can yield around 2 to 2.5 ml of vitreous with this technique. Once the adequate vitrectomy has been done, then you have to, as I showed that I wanted biopsy also here. So with the laser, I made a retinotomy, and then with just the passive aspiration, active aspiration held by the assistant, I took out this fluid from here. You will see that we have used this syringe there, and this technique is it can be used with the MIOCT because we are exactly able to see that whether we are able to pick out the cells, get the cells into the silicon tip of the aspiration needle or not. You see that MIOCT has been used in this case. We can appreciate the movement of the cells within the silicon tip cannula, making sure that what we have achieved, what we have gone inside the eye for. So in the end, when we come to the diagnostics and complications, they vary from pathologist to pathologist, surgeon to surgeon. But we have to remember, we have to work as a team. Once we are planning to tread into these fields, that we have to make a team which will consist of a cytopathologist, histopathologist, and cytogeneticist, because teamwork is going to be the key in colorectal biopsies. Thank you so much once again, Dr. Guga and and AOS. Thank you so much.
Thank you so much, sir. That was an amazing presentation over there. Thank you so much. Now, moving on to our next speaker, I would like to invite Dr. Nishikant Borse, sir. Sir, a very warm welcome.
Hi, are my slides visible?
Yes, sir, it is.
Okay. So I'm going to be talking about submacular hemorrhage management. As we know, submacular hemorrhage, it results either from a choroidal bleed or it results from abnormal retinal bleeds that come in. It is most commonly seen in case of neovascular age-related macular degeneration, or commonly in case of PCVs that we see. Now, the conditions which are associated with CMUM using, including myopia, trauma, ocular histoplasmosis, angiostrics, can also lead to submacular hemorrhage. Now, why is submacular hemorrhage so important? Okay. And why does it need an early treatment? The basic thing is there is a presence of iron, hemosiderin, and fibrin in the blood, which has got toxic effects on the photoreceptors. Even the blood clot that can retract can cause a shearing effect with a mechanical traction on the photoreceptors, thereby damaging them. And even the physical separation of the photoreceptors from the RP for a prolonged period of time due to a submacular hemorrhage, which may not be resolving over earlier, can cause a scar or damage to that particular area of photoreceptors. And since the mechanism of damage are time dependent, we actually need to have an early intervention in this case. Now, how do we classify it? The basic thing we have to understand that the thickness of the hemorrhage is more important than the size that we see as disc diameters. Because you can have a very small bleed, just about half a disc diameter at the fovea, which is very thick, which can damage the fovea more than a 3 or 4 disc diameters hemorrhage, which can actually just have a very thin submacular hemorrhage, and then that can be observed. It really does not need any active treatment because it may not damage the photoreceptors as much as a thick submacular hemorrhage. So the thickness is more important than the size, that I would say. Now, when you get a case of submacular hemorrhage, I think the most useful would be an ICG to know the site of the CNVM, because an ICG has an infrared camera which can penetrate through the hemorrhage and which can tell us about the choroidal pathology, if any, which is there. OCT is important because, like I said, it tells us the size and the location of the submacular hemorrhage, because if it is sub-RPE, then a surgical treatment may not work. But if it is subretinal, only then a subretinal surgical treatment can be attempted. Now, going to the management, we can either have the options of observation, anti-VEGF treatment, or displacing the blood with the help of intravitreal gas with or without TPA, or surgical displacement. Now, this is the case of a very mild bleed which was due to a lacquer crack, or if you have a trauma or a choroidal rupture with a mild submacular hemorrhage. Here you can just observe, and over a period of time, you can see the hemorrhage goes off without much damage to the photoreceptors. And this is a medium-sized submacular hemorrhage, which is thin. It is not very thick. It is from CNVM, and just by giving anti-VEGF agents, you can see that the hemorrhage has got cleared and the patient recovered a good amount of visual acuity. Now, when you have a thick submacular hemorrhage which is not going off easily, then you might have to do displacement. And the displacement can be done either just by gas, with or without TPA. Now, you can choose only to use gas, which is a very cheaper option, just office procedure. The only problem is it takes a longer time to displace because it takes time for the clot also to become liquid over a period of time. The complications, as usual, can be vitreous hemorrhage, endophthalmitis, or RD, which is associated with any injection of gas that is given inside the eye. So this is such patient in whom just a gas was given, and you can see that it displaced over a period of time. About 7 days time it took to displace, and the patient also has to maintain prone position for that much amount of time over a period of that many amount of days. Now, when you use TPA, the only advantage that you get is there is a faster displacement because the TPA will, of course, liquefy the clot. And like just a gas injection, even this is an office procedure with the complications remaining the same. Now, this is a fairly large submacular hemorrhage, and here just giving a gas wouldn't have worked. So I've given TPA and gas and given the prone position. And now you can see even this type of a thick gas could be displaced by a gas injection. Thick hemorrhage can be displaced just by a gas injection given along with a TPA. Now, if the thick macular hemorrhage is very thick and it is less than 3 weeks old, or you're just involved or just inferior to the fovea, then you can think of a pneumatic displacement, because if the hemorrhage is above the macula, then there are chances that it will get displaced into the macular area further when you're trying to do this particular displacement. Now, what do you do when you have a very large submacular hemorrhage or a very large superior submacular hemorrhage, which can slowly migrate to the center of the fovea? There you can attempt a surgery. Now, here I usually like to do a vitrectomy with a subretinal TPA with Avastin and air, followed by a fluid gas exchange. Now, this is a case of a large submacular hemorrhage, and in whom I have done a vitrectomy and I've cleared off the macular area of all the membranes. And then this is a 41 gauge subretinal cannula through which I'm injecting subretinal TPA along with air and Avastin. So as you know, I will zoom down, you can see the bleb coming up. There, the bleb is coming up. Now, what happens if you give subretinal air is that you get a very large bleb. And when you get a large bleb, you have that much amount of space in which the liquefied blood can migrate to. And then basically what you do is just a half posterior chamber fluid gas exchange. That you can do by judging the depth of the flute needle that you're using for an FGE. Now, this is the needle that is used, and the main thing for doing a half FGE is that the upper half of your vitreous cavity is filled by gas, and the tamponading effect out there prevents this blood which gets liquefied from moving upwards, rather it moves downwards. So you can see this is the hemorrhage, and just 4 hours after the surgery, the gas is filling the upper half and it's preventing the blood from migrating upwards, and it actually pushes the hemorrhage down into the area which was expanded by the subretinal injection of TPA Avastin with air. And you can see that within 4 days, the most of the macula is clear and just a bit of hemorrhage left behind, and this patient has done extremely well. So there are 2 things that are important: a smooth injection without being rushing into the injection, injecting just the right quality of air to giving maximum expansion, and most importantly, doing a half fluid gas exchange so that you have a tamponade in the upper half of the retina, preventing the migration of the liquefied blood into the upper half. Of course, if you have a very large hemorrhage, then you have to go ahead and do a retinotomy on the side and approach the subretinal area, and the hemorrhage then can be taken out with the help of a cutter, and then you can settle the retina back after you remove most of the blood from the subretinal space. Sometimes if you see an associated CNVM with a scar, you can even remove that since you're anyway in the subretinal space, and follow it up by injecting PFCL, doing laser, and settling the retina. So to conclude, submacular hemorrhage is a potentially visually devastating condition, which is most commonly associated with CNVM. Given its poor natural course, various forms of treatment options have to be tried with variable success, but we have to treat it, because if you just leave it there, it's going to cause irreversible visual damage. We can try office-based procedures with or without TPA, and if there's a very large hemorrhage, then you can try a submacular surgery by injecting subretinal TPA and anti-VEGF agents. Thank you. Thank you very much for your patience listening. Thank Dr. Goa to include me in this IC, and thank you AIOC for giving us this opportunity.
Thank you so much, sir. That was a wonderful presentation there. Now I think the other speakers are missing. So we would open the session for the discussion.
Padam, Dr. Ajay will be joining shortly. He just gave me a message.
Okay.
I think we have a lot of time. We still have, I think, 50 minutes.
Yes, sir. Yes, sir. In the meantime, we can start with the discussion.
Yeah. And if we have time, Dr. Nishikant, can Dr. Guha had sent me one small video. If we have time, I can show that on his behalf.
Why don't you show that now, since we are waiting for Dr. Arora anyway?
Okay, right. So I share my screen.
Yes, sir, please.
Yeah.
This was what he was going to show us about the RPE choroid transplant in large CNVMs. So what he does is here, just play the video. So once he has created this retinectomy, he creates a retinectomy under PFCL. So he has injected PFCL, and then he creates this retinectomy. He almost 180 degrees temporally does it. So first he is just creating a retinal detachment in this case by injecting saline below the retina. So now he has created a retinectomy and he flips the retina over. Now he injects some PFCL below the retina in this place just to keep the retina flipped over and does not hamper when he creates the graft. Then by using diathermy and by using laser, he marks the area where he has to create a graft. With the help of an intravitreal scissor, he just dissects one graft, this RPE choroid graft. and then he slides this graft with the help of end gripping forceps, and he takes this graft and puts it in the macular area. Then he removes the PFCL that was present in the subretinal space, and he uses the same PFCL to flatten the retina. And the laser is done, and silicone oil is then used as a tamponer. So this is his technique of doing autologous RPE choroid graft.
All right, sir, we can take questions now. If any questions from the other speakers, we could do that.
So Sangeet, I'm going to ask you, suppose you find the place of impact very close to the macula. Would you still go ahead and do a chorioretinectomy, because the hemorrhage from the choroid and all can actually be detrimental if the bleed occurs near the macula?
Yeah, people have done chorioretinectomy even in the foveal area. What they say is, I did not have a chance to do that, but they say that ultimately the vision is better if you do a chorioretinectomy rather than not doing a chorioretinectomy, because the PVR that happens, the fibrous ingrowth that happens, it will keep on recurring, and the ultimate visual acuity will be much less. And because of the impacted foreign body into the foveal area, already the foveal area is damaged. Already the photoreceptors are damaged in that area. So I think Dr. Sengul, she has shown a few cases in which she has done foveal chorioretinectomies, and she has got good results with that.
Sangeet, can I make a point here?
Yes, sure.
This is there was this case where you did chorioretinectomy, and both the vessels were that led to a BRVO kind of a thing there. Can a limited chorioretinectomy can be done, maybe a barrage kind of a C near the foveal center, so that if major vessels can be avoided? So you had a case where
you try to avoid the major vessels. That was the first case that I showed, I think, which had a BRVO post-operatively. Although he did not have a major occlusion, but few small intraretinal hemorrhages were seen along the vessel. And you try to avoid the major blood vessels when you're doing the chorioretinectomy.
I have a question for Dr. Nishikant also. Dr. Nishikant?
Yeah, tell me, Ramandeep.
Yeah. Do you look at the color of the blood? Is there any value of looking at the color of the blood before saying that you will attempt, or you will attempt in every case, or the timing is one you keep in mind? The TPA in subretinal TPA or with the air?
Yeah. So the particular case that I showed you came to me 7 days after his vision was diminished. Because
the one with the yellow blood. The one with the yellow blood.
So he came to me and I operated him on the same day. Now, what happened is you really didn't have much choice, because I would definitely like to do it as early and rather wait till it starts showing yellow, this and all, so that means the damage has already started. So I would like to immediately go in as early as possible. But the reason why I showed this case is to tell that even if the patient comes to you after 5 to 7 days and you find the blood has started becoming yellow, you still can go ahead and do the surgery and salvage some vision at least for the patient.
What is the upper limit then? I mean, they say it's within first 3 weeks. Some people talk about time. Some people talk about color. I mean, do you have anything?
I would say do it within. I would say do it within a week or two. I would rather do it immediately if I find a very big ocular hemorrhage. Why wait? Because we know it's going to damage it at all.
No, the patient
but if
comes late.
The patient has come late. Yeah. I would
It
wait.
comes at
I would
3
still
weeks.
attempt up to 3 weeks. Yes, I would. Try to give as much as possible, best possible chance for visual recovery, because we know the longer you leave, the more it's going to damage. If it's not gone for 3 weeks, it's no chance that it will go on its own just like that.
Of course, the prognosis, you can always talk to the patient about the that visual prognosis will be poor.
Yeah. So actually, there was one more video I did. The patient came to me about 4 weeks after the hemorrhage, and he was conserved by the first treating physician until he came to me for the second opinion. So after doing it, he has hardly got back 660 plus 1 letter. That's it. So most probably, obviously, the damage was too much, and unfortunately, that guy is a physics guy, and he really was very keen to preserve his vision, but he came quite late, and that's
Absolutely.
the thing. But at least from finger counting, he improved to 660 plus, so that is good enough.
And you add this.
Sorry to interrupt here.
Yeah.
We have Dr. Ajay Arora sir with us. Once we finish with this presentation, we'll continue with the discussion.
No, I think let them. I think the discussion is good.
No, please, Dr. Ajay, you are here. We have a privilege
I'm
to
so
listen
sorry.
to you.
I'm so sorry. I was there in another place. So I rang up Dr. Gua and he said to contact Sangeet. So I sent him a message. I'm so sorry.
We were just chatting and passing time.
Achha, I thought no. Okay. No. Carry on. We can carry on to the logical. In fact, I also have recently had a patient who has been to different places with the subletting lead, which was from a 93-year-old man who had IPCV, and but he would not like to get operated. He would not like to. 93.
Okay.
Yeah. So he was told, he was given an anti-VEGF, and he wanted a guaranteed success, and he came to me at 3 weeks. So what do you do at 3 weeks here?
Don't guarantee anything.
So I said, go back to the treating physician where you got your anti-VEGF.
Go ask the God.
Yeah, 93 में क्या करेंगे? वो भी COVID times में. He's recently recovered from COVID. I said, this is a little spicy.
So Ajay, if he can beat COVID, he can even beat the sub.
Yeah. So he is.
Oh my God.
So I should share my.
Have you seen a foveal blowout with the air, and how do you prevent?
Yeah. So Sangeet has got a very interesting video on that. He has got an interesting video where
that blowout is different. Your TPA blowout, TPA plus air blowout.
Yeah, that not the choroidal blowout. I wanted to know if you've had any issues.
No. Sangeet has got a video in which the air was injected too fast and there was a blowout. So you have to be very careful in injecting. It has to be very slow. If you go fast, then definite macular hole. So,
I think air adds to this problem, because you see the TPA and the fluid goes more controlled, but when the air bubbles, they just rush in, and they just with an increased pressure, and the chances of blowout, I think, is more with air than with the TPA alone. But I have seen blowout happening in both the ways.
So
the air contributes because that is the last thing to go in, because when you hold it, obviously the liquid is going to go in first, and then it's already, the retina has expanded quite a bit, and then you're going to expand it further with air. So the volume becomes just too much when you inject air.
And you see, if you apply the same amount of pressure on the syringe, the fluid takes more time. The air suddenly you just push it in suddenly.
So for this, I think the best way should be to have a mechanized injection rather than manual.
Yeah. That's what I said was like to use. If you use an automated injector, it gives you better control and better.
So Sangeet, very soon we have now made a new injector. Right now I can't say, but that is working beautifully well. We have done a few cases of subletting injection, and it's a very simple thing, and hopefully should be able to see the light of the day very sooner or later, which works very well.
So Ajay, what Sangeet does? He cuts the 1 cc syringe into half. He cuts the plunger into half, And then with the he cuts a bit of a tip of the 10 cc syringe and puts this contraption into the 10 cc syringe with the drug loaded, and then he puts it into the silicone oil injector for injecting, and he's developed it a
Yeah,
very
I've seen that.
simple thing.
I've seen his video.
Yeah,
Ours is also something similar, simple. Though yes, it's
yeah,
something else. But yes, I'll share it with you.
yeah. Yeah, good. We hope to see it soon, Ajay.
Yeah,
Come again.
okay.
You can send one to me to evaluate if you want to.
Okay, got it.
I had a question for Dr. Ramandeep, that for the biopsy for like lymphoma, can you use like a 27 gauge system and, not, go make a retinotomy and then, with the soft tip, instead just go in with a 27 gauge cutter and, use that?
The transmitral biopsy is very much possible.
Right. With the 27
Yes,
gauge.
it is possible, because if I talk to Prithvi, he says it's a doable, but I have not done it. Without disturbing the vitreous, you go to that site and remove this thing. It's very well possible.
No, but sorry, I missed your talk, Ramandi. But for a subretinal biopsy, would you use the 27 gauge or use the 39 gauge cannula to remove the cells?
I mean, this is there is a new technique. This Dr. Prithvi and the Raj group, they are talking about. What they do is they make this 27G gauge system, and directly they go into the tumor,
Right.
right? And they push the 27 thing into the tumor. If they are not able to do that, they will make a hole with the 27G needle and push the cutter inside, and with the high vacuum and low cut, and they will run the cut there, and then they will simply come out. All right, and they will come out. Some bleed will happen. They say that bleed will have to help to clog the retinotomy, and you don't have to laser it. So that is what we are talking about.
Something like an FNAC, something like an FNAC.
Yeah. But with the cutter, the yield is more.
Right. So let me share my.
Yeah, Dr. Ajay, to let him finish his talk and then we can discuss.
Yeah, this is the last session. So I think all of you may have already seen part of it. This is nothing new. But he asked me the suprachoroidal injections. Thank you, Sangeet and Dr. Goa, for giving this opportunity. So I'll be sharing this. So basically, one could give drugs to the eye by multiple techniques, systemically, topically, periocular, intravitreal, suprachoroidal. And the best route for bioavailability of the drugs to the posterior segment is intravitreal. Because it overcomes the blood-retin barrier with a minimal systemic effects. The disadvantage of giving us in the suprachoroidal space, the volume is less, needs to be repeated. It can, if you give an IVTA into the vitreous, it can cause cataract, can cause glaucoma, can cause endophthalmitis, vitreous hemorrhage, vascular occlusion, and retinitis. Now, targeted administration to the suprachoroidal space started off with this seminal work by Patel et al., which when they created a proprietary microneedle, which essentially this is what the microneedle looks like as compared to the hypodermic needle, and that's the sizing basically. And then it was found that if you do a single suprachoroidal injection of blue latex, it spreads to cover more than 50% of the posterior segment. Suprachoroidal space can potentially accommodate up to 1 ml. So basically saying that a large area of the posterior segment gets exposed to by a single injection of suprachoroidal. Now, a proprietary microneedle system came out with a Clearside group. You must have heard a lot of studies. And then there was developed by this system was developed by Med1, but it has been discontinued because it's no longer available. It requires clear incision, and they have discontinued. The Clearside system is not commercially available, and we have this jugaad which has been created. I've tried this, but at many times it really doesn't work, where you have a 30 gauge needle passed through a shortened 23 gauge needle. The needle juts out 1000 microns it is doable. People are doing it, but every needle, and Tricon makes it, but it doesn't succeed with every. So the question was, can we use a normal commercially available needle which has got a bevel length of 1500 microns and yet succeed? Is it possible? So we did a study where we basically the principle was that if you go through any rectangle vertically, you'll be traveling a smaller distance as compared to if you travel obliquely. And if you change this angulation, the distance traveled will become much more. So this is just some basic physics. So if you have a needle which goes in obliquely versus goes in vertically, it can, and if you can work out the details, you can actually go into the suprachoroidal space. So we created a nomogram of the angle of entry. We did some animal studies where which was done in both sides, where we injected methylcellulose Helon and evaluated it on the UBM and after anatomical dissection. And this is the instrument where it's being done on both sides, and you can see that it has been injected in the suprachoroidal space, and then we will go ahead and dissect it out. You can see now we are dissecting the sclera, and we can demonstrate the triamcinolone in the suprachoroidal space. We did that injection of triamcinolone, methylcellulose, and Helon, and evaluated it on the UBM and found that yes, with Helon we were able to create much greater separation. So we then tested this device in human eyes, and now we have, this was just the initial thing. We now have over 82 eyes which we followed up these cases, and this has been done for diabetic retinopathy, central venous occlusion, post-PPV, ERM, macular edema, post-rear surgery, silicone injection with traumatic disassemblage, and retained intraocular foreign body with macular edema, and many more cases. So this is just some videos which just show you the drug being injected, and the injection happens very neatly. There is not much problem, but yes, there is a little learning curve, and if you don't do it carefully, you will definitely become intravitreal. That's the worst complication that can happen, that the drug becomes intravitreal. But otherwise, most of the time you are able to succeed. And we've had in this 82 eyes, we've had 4 situations where it became intravitreal. So this is a little bit of our data, and this is some patients, like this is a 68 years old female who had diabetic macular edema, which is cystoid in nature. Patient had earlier received anti-VEGF, had also received Ozurdex, and this device was ready at a time when Ozurdex was not available in our country. So patient was not willing for partial vitrectomy with a near field. So we decided to inject, and this is what it is. This is pre-injection. This is at the second day of injection. This is on the 11th day of injection. Usually it is from 6:36 to 6:18. And this was a dramatic case of a patient who was diabetic, hypertensive, pseudophakic, lasered, and was also glaucomatous, had received Avastin, Lucentis, and Ozurdex, and then Ozurdex was not available. So this is the right eye, that's the left eye, had all the biomarkers for a steroid injection benefit of this thing. So this is pre-operatively, sorry. This is pre-operatively day 14, day 34, day 70. And this patient, we had to repeat it after the 88th day. So patient did pretty well. So what are the future prospects? Suprachoroidal space injections are the future for retinal and choroidal pharmacotherapy. The Clearside group, the cost is more than 25,000. With this particular device, the cost is only the cost of the needle and the cost of triamcinolone. The device which are made there are multiple devices based upon the thickness of the sclera and the angulation, and there's a nomogram which I follow. And this device can be used, it is autoclavable, can be can inject at varying depths. We can even mechanize it. No sleeve incision is required and can be used for suprachoroidal. Thank you for your time.
Thank you so much, sir. It was a wonderful presentation. Now, again, we open the session for the discussion.
Thank you, Dr. Ajay. One thing I always ask for suprachoroidal injections is if something happens, if something goes wrong, how can you remove this from the eye?
I fully understand. I think because Ramandeep is sitting here and Professor Amod Gupta had also.
What will go wrong? I mean,
The only thing that can go wrong is infection. So that can go wrong with any drug which we are using in this for the eye.
I think if it goes inside the eye, it's the right thing or wrong thing.
No, he's saying that if what will go wrong, the only wrong I'm worried about is infection, right? So if it goes into the right space,
my question was, I mean, we've been always told to put it near the foveal center. So why aren't we doing it here? Why are we staying so anterior?
No, why should you put it close to the foveal center?
Because more you near the ciliary body, more are the chances of causing high pressure. You know.
No,
no. If you read Harris, if you read the monkey eye studies, this is what they said when the this posterior subtenon tenon injection came, and then people talked about giving posterior subtenon with a vein fluid. Dr. Pradeep Venkatesh. At that time, people studied that more near is to the limbus is chances of pressure more closer to the fovea, the chances of pressure increase are less, and it will be more effective. And this is my take. You know, I mean.
Okay, so let me just clarify some basic anatomy points here.
Mm-hmm.
Suprachoroidal space anteriorly is it extends anteriorly and posteriorly. Anteriorly is blocked by ciliary body, and posteriorly is the optic nerve. Right. So if you inject it in the suprachoroidal space, it will never ever get into the trabecular vestibule. So there are a lot of animal studies. So what you're confusing it with the subtenon injection versus the suprachoroidal injection.
That's right.
Subtenon injection is exposed to the entire sclera. A suprachoroidal injection is restricted to the suprachoroidal space.
Mm-hmm.
So when you inject into the suprachoroidal space, that IUVS article which I showed you, it covers more than 50% of the posterior segment by just a single injection. When we did the injection of suprachoroidal triamcinolone, we tried to do UVM immediately. We wanted to know how long it takes for the drug to spread out. And it spreads out so rapidly that we were not able to demonstrate. That is why we did the experiment with helon and methyl cellulose, because in an animal eye, we could inject and create a large space in the suprachoroidal space. But the suprachoroidal space is so open that it just spreads out completely so rapidly and goes up to the fovea. With the same idea in mind, which you're suggesting, they created an illuminated catheter, which was created by Med1, that you could actually go into the suprachoroidal space and track down the illuminated catheter viewed through a biome vitrectomy and see. I have a good video of that. I could have shared it, where you could actually go. But then they found out that it is not necessary. There's a lot of studies which have been done. The first paper on uveitis came out from Chicago by Goldstein et al. And they showed that in the entire group of patients where they had given suprachoroidal injections, they had less than 3% patients where the intraocular pressure did rise. All the other patients, the pressure did not rise. The patient I showed you was a glaucomatous eye where we gave suprachoroidal injection. We have repeated in her 3 times over a period of 1 year. The pressure has not risen. And so I've had one patient where I've given suprachoroidal, the pressure has gone up. But now we have actually modified our drug dosage a little bit, which I'm not sharing here. But yes, we've done that. And so suprachoroidal injection does not lead to an increase in intraocular pressure if it is done correctly. If it goes intravitreally, yes, the pressure will go. If it remains outside the sclera, again the pressure will go. In the suprachoroidal space, no.
So one more thing I would like to ask is like, because suprachoroidal space, okay, but there is no space over there. So how do you actually know that you are in the right place where you're injecting?
So the moment you are in the suprachoroidal space, there is a feeling of a give. There is a feeling of a give which I cannot explain. You will only feel it. The moment you feel it and you start injecting, it will start flowing freely. So it can flow freely only at two instances. Either it is in the suprachoroidal space or it is in the intravitreal area. If it is in the sclera, you will not be able to inject. So if you are having a resistance, do not inject.
Okay, thank you. Great one. Yeah. Was the is it commercially available now, Dr. Ajay?
It's not yet commercially available because I.
What about friendly availability?
Yeah, friendly availability hai. It's definitely there.
As
Because
Nishikant said, friendly. We are
actually we had applied our papers for the patent and everything, so that's all done now. They can go ahead and do it. Not that I have any commercial interest in it, but just for the heck of it, I've done it.
No, I got that.
Yeah. So
it's no harm having commercial interest also.
जो भी है, all my instruments I've hardly.
Dr. Nishikant, हमें मिल रहा है we'll get one, friendly.
Always willing.
I have sealed the deal now, right now.
Done.
National podium.
Any incidents of suprachoroidal hemorrhage, Dr. Ajay, in your device?
No, not a single That's surprising. I was worried about suprachoroidal hemorrhage, but surprisingly not a single suprachoroidal hemorrhage. So the only thing I am worried about is from the study from PGI where they had tricot and they had fungal endophthalmitis. That's my worry, boss.
I think that is to do. I mean, that thing you have to take care, that sterility of the tricot. That is not in your hands.
But in case the drug comes infected from the company, तब क्या करेंगे?
वही कह रहा हूँ ना. I mean, that is not in your hand.
Yeah. So that should not deter us. That is my only worry.
Absolutely.
Otherwise, I really don't worry at all, because you cannot cause a suprachoroidal hemorrhage. The only thing you can cause is it becomes an IVTE basically. And the moment it becomes IVTE, you can just stop it, choose another site or choose another day and then do it, and don't persist at the same time. Because even if so I've done this, I've chosen another site, but once you have punctured that area, even if it is on another site, some of it goes back and trickles through that site if you are close by. If you go diametrically opposite, then it doesn't happen.
I think you must have seen that videos by Egyptians where they put this suprachoroidal helon to seal the break.
So I
show that actually.
Correct. So that was through the Med1 cannula, and last time when I was at the academy, I went to the Med1. This is by Dr. Rice et al. Dr. Rice had come for this thing, so I went to him and asked. I asked them. I said, I want that cannula. I want to buy it. They said, sir, we have stopped making it. I said, but Dr. Rice is, this thing. So then we asked Dr. Hassan Mortada as to how many cases are being done in Egypt. Not really many.
Okay.
Yeah, but it was a good thing. If the cannula was it's expensive, but yes, it would have been nice to have.
I have got 3 to 4 cannulas which I got when I had gone for the Frankfurt Retina meeting. So I met Dr. Rice there, and he actually gifted them to me, so I could use them. But it's not so easy. It's not so easy because unlike your technique, you have to make a nick in the sclera and then dissect up to exactly the choroid, and then you have to inject a visco between the sclera and the choroid to make a space, and then you have to put the cannula inside.
Correct.
It's slightly a complicated procedure.
And they also have an olive tip cannula where you can go into the suprachoroidal space.
Yes, but I have spoken to many of them, and they have experienced a lot of suprachoroidal hemorrhages because even if the olive tip is going through, you can always rupture any choroidal vessel.
Yeah. In this one, you are in the suprachoroidal space, and you really don't traverse much in there. You traverse the suprachoroidal space.
There you traverse, no? So, you
Yeah.
can always,
Yeah.
there are blood vessels which are going to and fro from the sclera
Correct,
and the
correct,
choroid.
correct,
You hit one of them, you're gone.
Yeah,
That's why.
That's it. That's it.
I think it's something to do with the volume also and how fast you inject, because it's a negative space and you are pushing something into a negative pressure space. If you push in too much, that it might cause bleeding. But I think with a little volume, it should not matter. Yeah.
No, see it's been calculated. In fact, we did that in goat eyes actually, which obviously it's not you cannot take it to the human eyes. But what they calculated in human eyes, cadaveric eyes, is about 1 ml can be injected. 1 ml is huge.
Huge.
We really don't need to inject 1 ml, but yes, with normal suprachoroidal injection, you don't have raised intraocular pressure. I think a coordinator is.
I had a question for Dr. Sangeet. Like for your chorioretinectomies, apart from 100% diathermy, you recommend that. Do you also increase the bottle height at that time, or?
No, you don't have to increase the bottle height at that time when you are doing chorioretinectomy. Only in the case if you have a lot of bleeding, you can do that. Most of the time, you don't need that also. In fact, the chances of PAFE syndrome, they do increase if you increase the infusion pressure.
Okay. And how do you
Saurabh,
avoid
any role of TPA for choroidal hemorrhage to liquefy it before we train?
So I have not tried TPA for suprachoroidal hemorrhage, but because I just follow the standard thing of serial ultrasound, wait for the liquefaction, and then then intervene. If it has not been done at the primary setting. So I have not tried suprachoroidal TPA. So I don't know.
It might not be a bad idea just to inject it into the clot if it's large enough, and you can
Right.
go in faster once it liquefies with TPA.
Right. So I think that's a good idea and a good thought that that can be done, and maybe you can intervene faster. Because otherwise the PVR is going to set in, and PVR is going to be very difficult to manage as time goes by if there are kissing suprachoroidal hemorrhage.
But the issue that might come up in that situation is how much of TPA would you inject and how will it populate to the entire hemorrhage? Because I had a personal experience many years back, and we had a patient who was operating who had multiple large hemorrhages. We were going to use TPA, and we ended up using a little more than what is required. And just one second. We injected a little more than required. Everything went off well, but surprisingly, post-operatively, patient had a few bleeds at different places. I do not know how it occurred. This is many years back. Whether it was excess use of PPA or not, I have no idea.
Is it reported? Is this reported, or
No. That's the biggest problem. We don't report things so easily. It's so stupid on our side.
So Saurabh, it is something which we all should try. Maybe we can report it then.
Right.
I think Saurabh, I think it is, if I'm not wrong, I think it is already tried, because the other day I was listening to one of the talks, the suprachoroidal TPA has been tried, we really have to search actually. So,
okay.
And would the dose be the same? I mean, like around 25 to 50 micrograms. Would the dose be the same, or would it change?
I think the subretinal dose should not be that toxic. Subretinal dose should be okay. The same dose can be used. I think so.
Right.
Because it will be far away from the photoreceptors, so I think same dose will be fine.
Right.
But I think somebody has tried it. I don't remember the exact now. The other day, I asked Dr. Sangeet the same thing. Dr. Nishikant, you remove that large clot from the subretinal space by causing a huge, retinectomy. If the TPA won't work there, it should not work in the suprachoroidal space also. I was just thinking about it. Just.
No, the point is, Ramandeep, if you have a very large or a massive bleed, just injecting a small TPA and waiting for it to displace on its own, it's not going to happen. So you have to actually go ahead and, remove it. Now, what happens is with a very large hemorrhage, how much of TPA can you inject? It becomes difficult. So yeah, technically you can inject a TPA on the day one and wait for 12 hours and then go inside and then, try to just remove it from a small retinotomy. Maybe, but otherwise the large thing is, especially if you know that there's a CNBM scar underneath, you can go ahead and do a retinotomy, remove the blood and the scar.
Hello, great thoughts. I think a lot of food for thought.
Yeah. I think we are running out of time.
Thank you, Sangeet. Thank you, everyone. And thank you for, seeing each other's faces. That's more important. With not meeting physically, but at least चेहरे तो देख गए हैं.
So, Saurabh, Mohit called me just now. 2011 में suprachoroidal use किया उन्होंने 100 microgram dose use किया. I'll mail you the case report.
Okay, thanks. That'll be
Mohit just called me. He's listening.
Yeah. There are two reports. One called Dr. Kunju in 2011, and second is by P5 in 2018. There are two case reports.
I'll look that up. Thanks. Yeah.
Third should be Dr. Saurabh Luthra now.
You can use a suprachoroidal. Saurabh, you can use my suprachoroidal device to inject.
Your cannula. Okay, got it. I got the cue.
Yeah, so the third report is going to be from Saurabh Luthra. Okay.
And all the other group members here.
Chalo, okay, guys. Thanks a lot.
Okay, guys. Have a nice time. See you.
Thank you
Be
so
safe.
much, sir. It was an amazing.
Hi, everyone.
Yeah, thank you so much. I thank all the speakers for the wonderful session here. And we come to the end of this amazing virtual conference. Thank you so much. Have a good day. Stay safe.
Thank you.
Thanks a lot. Thank you.